This program is brought to you by Stanford University. Please visit us at stanford.edu.
Our next speaker is a really remarkable individual, Alan Daugherty, who's chief of the Cardiovascular Research Institute at the University of Kentucky. Alan's a recent past president of the ATVB Council of the American Heart Association, and I don't think in my professional career I've ever met a volunteer who's as enthusiastic as and effective in his work in nonprofit and advocacy organizations as Alan. I mean, Alan's like Mr. American Heart. I think if you took his dress shirt off, you'd probably have an AHA T-shirt on underneath there. You know? And Alan has been really a leader in recognizing the influence of angiotensin in the progression of both occlusive and aneurysmal vascular disease, but has made many remarkable insights into the role of angiotensin in the induction of aneurysms, and it provides kind of a complementary look at aneurysm disease. As most of you know who are interested in this area, these days to publish an article in a top-flight journal, you need to show your influence or your interactions in more than one model because of these issues that came up in our discussion about some limitations of the elastase model. And our lab also now uses this angiotensin model, and I had good fortune of visiting Alan's unit earlier this year and is really impressed by just the productivity and enthusiasm for aneurysm disease that they have in their area. So anyway, Alan, thank you very much for joining us today.
Thanks very much. Well, as he said, I am a bit of a cheerleader for the AHA, and especially for their fall sessions, which are huge. But I must admit, I think what Ron's put together here is much more effective in terms of coming together and having small chit-chats about sort of the nitpicky details that I think are very important about different experimental models. So the one that I'm talking about is the angiotensin infusion. I've actually modified the title a bit to take out ApoE, because you'll see that particular facet is not a requirement of generating angiotensin aneurysms, and you'll see that as we go along, not just from our lab, but from others. I also would actually refer you, I might mention a few things about, we do have a few protocols posted on our website that one issue actually came up this morning that I'll just mention that I think is important for this facet. So the renin-angiotensin system is very historic. Renin was discovered in 1895, and it's been known as a system that's very important for blood pressure for over 100 years. This is a sort of standard scheme you'll see in textbooks, but it's a bit out of the realm of today's talk, but this has actually now got to be a very complex system. And in fact, even though we're listing this as the bioactive peptide, there's a whole series of bioactive peptides and also a whole series of potential enzymes that can lead to this endpoint of getting these bioactive peptides. In terms of its role in the human disease, it's somewhat nebulous, frankly, at the moment. There's been quite a few studies on this insertion-deletion mutant of ACE, which is the second step in the generation of angiotensin II. Some have shown it to be negative, and some have shown it to be not involved. There's been a relatively recent study about this kind of interesting polymorphism, the A1166C, which is in the 3' untranslated region of the angiotensin receptor. And even though you would think it doesn't have function, it clearly does. And there was a multinational study that came out of New Zealand, Australia, and Great Britain that showed that this was one of the most, in the angiotensin system, one of the most common factors that seemed to be related to the development of aneurysms. And then finally, this one, which came out 2 years ago, which actually Frank and I were just at a meeting just as this came out. We had lots of discussion about this, the fact that a study came out of Ontario that did retrospective analysis looking at what drugs people were in once they entered a hospital in the Ontario healthcare system. And the conclusion was that those individuals that were taking ACE inhibitors had a lesser incidence of rupture. And so there was this issue that maybe actively taking ACE inhibitors was a preventive measure. Now, in my own world, I moved to Kentucky actually 11 years to this week, and I hooked up with Lisa Cassis to, initially our thought was that Lisa's been a long-time angiotensin expert. She's worked on this for over 20 years. I've worked on atherosclerosis for a long time. Our original intent was to follow an NIH-RFA to create a hypertension-induced model of atherosclerosis. So we started these models where we infused angiotensin into either ApoE or LDL in very short term. And I'm not going to give the data, but basically it was very obvious that angiotensin is one of the most profound producers of atherosclerosis that I've come across. And this is a world that I've been in for an awful long time. Another feature that we've also noticed in this case, not just in ApoE and LDL, but also in normal, is that these mice do actually get this very interesting ascending arch aneurysm. And I don't know whether you can see it in this particular picture, but the pathology stops right at the subclavian. As soon as you hit the descending aorta, all these changes that you get during angiotensin infusion are not occurring. And of course, this is of interest because of the study that's already been mentioned, the fact that there's a clinical trial ongoing for patients with morphans giving losartan to show whether losartan administration causes dilatation. And then finally, of course, this production of aneurysm that occurred purely by serendipity. And part of the reason this caught our eye was because in the early 90s, when I was at Washington University and had the good fortune to have Rob Thompson and Greg Sicard as my colleagues, I'd actually looked at a lot of human aneurysms, and in fact, Rob and I had lots of chit-chats about the fact that this is an under-researched field, and one of the reasons that it was under-researched is because of a lack of animal models. So when this came in the late 90s, when I was in Kentucky, we latched onto this as a potential model. This is a really simple model. This is just an indication of, and this is not exhaustive and inclusive, but it gives you an idea of the different labs that have used this to generate angiotensin-induced aneurysms. And I think part of the feature is that technically it is very easy. Even I've done this. It's that easy. The only feature actually I should mention, because this has already come up at breakfast this morning, is that some people have contacted and said they don't get aneurysms. And again, that's why I refer you to our website, because one thing I can tell you is that angiotensin loves glass. And I actually don't know why Sigma supplies the lyophilized material in glass, because if you dilute it up in the glass, your angiotensin's gone. You have to do everything in plastic, and it's, as I say, one of those little quirks that once people have overcome that, generally it's been very easy to do. There are a few characteristics model that I'm not going to go into in great depth. One of the more intriguing ones, which is the focus of Lisa's lab, is that there is a definite male-female difference. And this is not a sort of a random, it's sort of a generalized increase in angiotensin responsiveness. So we don't find males and females more responsive in hypertension responses. We actually don't find them any difference in atherosclerotic responses either, but they are very different in the way they respond to the aneurysm, with, as in humans, the males being much more susceptible to this progressive dilation than females. I should also mention, again, I'm going to cover a lot of studies that I won't give you a lot of nitpicky detail, but I do want to accentuate a few things. One is that everything we do, we always measure blood pressure. And I think I can fairly unequivocally state that, again, a bit like actually what Frank was saying for the humans, this does not, even though angiotensin is well known to increase blood pressure, the development of the aneurysms does not require increased systolic blood pressure. Likewise, this disease can happen in normal animals. And Gary Deng, who's in the audience, first published on that, and we can see that very routinely. There is an increase in the incidence if you do it in hypercholesterolemic animals, but the disease in our hands, and I think the same with Gary, looks identical whether you do a normal lipidemic animal or a hyperlipidemic animal. And finally, we get asked a lot about fluid balance and salt balance. And in fact, we, in our hands, can't find any effect of aldosterone in this particular disease. One of the sort of challenging issues is that things change over time. So we did publish a paper showing the changes during the first 28 days that occur after angiotensin infusion. In fact, Deborah Terry, my colleague who's at this meeting, is going to have a poster in which she shows the characteristics going further out, up to 3 months. And these changes are very profound over these 3 months. By the way, that's not gone green. It's because the dilation becomes so big. The normal here is usually about 0.8. We've had ones going up to 4.5 millimeters, and they get so big and difficult to section that we have to perfusion fix these animals and put this low melting weight agarose with a little bit of green food dye in there, just again like the Berlex group did, just to make these aneurysms more visible once we're actually sectioning and also somewhat supported. So there's a lot of temporal changes over time. In terms of the features that you see, again, this is the publication that we had in 2003 in which we took an extensive number of animals and sectioned them between 0 and mostly 28 days. And we pointed out certain features that seem to be common to the human disease of inflammation, in this case atherosclerosis, which occurs as a subsequence of the disease. There's an unequivocally fragmented elastin fibers, you get proteolytic destruction, and you get this areas of intact intima, but it's very heterogeneous. One of the issues that I'd sort of invite you to go to with Deb's presentation of the posters is that not only do they change over time, but it kind of depends where you look as well, and you can get a very different impression from that. So what you're going to see is a very tedious study that Deb's done, where she's done sectioning throughout these whole tissues, and basically we've got whole banks of these tissues, which we've found it's pretty important to look at a whole bank because the heterogeneity you get as you go down the aneurysm is quite profound. And again, looking at my experience when I was at Washington University, seems to be consistent with that. When Rob and Greg used to give me human aneurysms, I'd go and section them, and I'd take them up to Jeff Safitz, and Jeff and I would spend hours sifting through this because the human aneurysm is extremely heterogeneous as well. And so just to take a pinpoint of one area and come to a conclusion sometimes can be quite difficult. So we can get these very profound dilations. As you can see, this is a normal one that's about 0.8. And I can show you tons of examples of dilation. Some have thin walls, some don't have thin walls. It kind of depends where we happen to select that particular section. The one nice thing about this model is that we can detect it non-invasively. We had a rather miserable time trying to take a clinical ultrasound to this model. They only tend to be 15 megahertz, and the quality of those ultrasounds, we couldn't really get that to the stage where we had much belief in it. But a group of Canadians have come up with this visual sonics. With this particular scan head hooked up to this machine, it's a very high frequency. It's a 40 megahertz. It has a 6 millimeter focal length, which is just perfect for us because just when you put the probe on the belly, the aorta is about 6 millimeters below the skin. And it has a resolution of 30 microns, which actually is not such a big deal because we have found that the extent of dilation is so large that the resolution actually could be a lot less, and we could still see it. And we have done these studies where we've taken 4 people. They've all independently taken the images, analyzed the images, and seen how close they can be. And if they've been doing it carefully, it's actually quite amazing how close these images can be. And just to give you a feel for what this looks like, I'm going to show you images where we've just handheld the scan, and we've moved it up through the renal branches here, and in both the saline-infused one and angiotensin-infused one. So on the hope that these films actually run. So I don't know if you see this, the lights at level, but there's the normal aorta, and you can see it both bouncing away to kind of an interesting way, and we've gone through a few branches there as we just move it up. And at the end, it's about 0.8 of a millimeter. In this other image, again, going up through the renal branches, you can see as it evolves, there's a branch there, and this is an image I took 3 years ago. This is one that we could reproduce over and over again. You can see it's very easy to quantify that luminal expansion. In our hands, we get asked a lot about going beyond the lumen. We find the quality of the reproducibility of people's measurements then is very low. So the lumen is actually very easy in our hands to measure. The outside limits of the aneurysm is not quite so easy. So I hope that's not like a little rearrangement of my thing when it's been transferred here. Hopefully that's not routine. So with angiotensin infusion causing this disease, in terms of mechanistic insight, one of the things we thought about was using receptor deficiencies to see whether we could pinpoint some of the cells that would be involved in the disease and then go into those cells as mechanistic studies. So angiotensin receptors in mice are actually a little different from humans. There's been some chromosomal duplications, and they have both an A and a B, whereas we should just have an A. In some ways, it's fortunate. It seems like most of the effects are with A, but there are some with B. As Rob mentioned, there is an AT2, which seems to, in our hands, do nothing except frustrators. The studies are done by Deborah Terry, who's in the audience. Just to stop any gossip, she's actually my wife as well, if you're wondering about our reaction. And the studies that we're doing is we do a lot of crossbreeding, where we'll take a gene of interest and crossbreed it into a hyperlipidemic background. In this case, we've got AT1A, wild type and deficient. They're all luckily strain matched in this case. Infused angiotensin, and I'm only going to be talking about the aneurysm responses in this study, in this forum, but we do measure atherosclerosis in everything that we do. So one thing was very clear when we infused angiotensin, basically you just need to look at this side there, is that the angiotensin caused the predicted increase in dilation that you see in the suprarenal area. And in the absence of AT1A, you get a total wipeout. I mean, it's not even a slight partial. It's clearly that even though there is this chromosomal duplication of two very similar receptors, it's the AT1A that is absolutely the requirement to generate this disease. So then what Deb did is to take the next step is to try and localize it between, is it just the leukocytic infiltrate versus the resident cells? And a very standard technique that we borrowed from the arthro field is to do chimeric animals where we'll take an LDL receptor, we'll take a AT1A knockout and wild type, and then we'll irradiate LDLs. And in this case, what we did do is LDLs were both either AT1A plus or deficient. So this is actually quite a big study because we end up with 4 groups of chimerics which have very different genotypes that are AT1A, either in the bone marrow-derived cells or in the rest of the body. And in this group of animals, we've infused either angiotensin or saline. So this is a rather large study, but I'm just going to cut down to this one study here, which is basically, if you take a knockout AT1 animal, it doesn't matter what type of bone marrow you give it, we can not get aneurysms, even though we proved the repopulation at the end of the experiment. So it seems like the AT1A presence in bone marrow is not the required factor for at least initiating the disease. So it seems like it's presumably something in the resident cells that's causing the disease, of which the most obvious thing, of course, would be either smooth muscle or endothelium. What we've done is we've paid a big check to a company to flux the AT1A gene. For those of you not familiar with this, this is basically where you put LOX-P sites either side of a critical exon within your gene, and then you crossbreed these mice to ones that express CRE in a cell-specific manner. And if all things go well, you'll have excision of the LOX sites and then recombination with a cell-specific depletion of this receptor. So we've created these AT1A fluxed animals with flux sites either side of the exon 3 gene. We've shown that there's no hypomorphic phenotype, which is an important consideration, and that we can get efficient excision of this exon 3. The breeding, which is quite heroic, frankly. Ron was mentioned about coming to our animal facility. We have lots of mice. Because to do this breeding is quite difficult because you've got to create a hyperlipidemic background that's homozygous for the floxing, and then in our case, we carry CRE in the male. And then we do the breeding of the male CRE versus the female non-CRE, and then you look at the litamate offsprings for comparisons. And we're doing these both for the SM22 to take out the smooth muscle, and we're also doing Tie2 to take out the endothelium. Deb's just got preliminary data. I'd say this is very preliminary in terms of a study which she's done where she's compared the wild type, the ones with a smooth muscle-specific knockout of the AT1A receptor, and then as a control, she's taken, oops, that should be knockout, sorry. I'm going to get blamed for that, I guess. This should be deficiency, AT1A receptor deficiency as a comparison group. So you can see this is very patriotic colors of red, white, and blue here. I found this very efficient because I can use the same scheme when I go back to Britain. So what we've got here, again, is a very small group of animals. To take the extremes, the dilation that you see during angiotensin infusion in the wild type and the knockouts, you can see it's very profound. And with these relatively small number of animals we got at the moment, this is the median for those that have a smooth muscle-specific deficiency of AT1A. And at the moment, it seems like, except for this one outlier up here, we seem to be tracking very consistently that the AT1A in smooth muscle is the factor that's promoting this disease for initiation. So our scheme at the moment is that we think the angiotensin is affecting the AT1A in smooth muscle. And our scheme for a grant that I'm just going to mention at the end was that we thought that there might be an effect of the smooth muscle affecting a really interesting protein called low-density lipoprotein receptor-related protein, or more easily said as LRP. And the reason that that might affect the disease process is because LRP interacts with UPAR, and UPAR is thought to be an activator of the urokinase system, which then can cause up this proteolytic digestion within the media and cause a provocation of inflammatory cells to come into the media. In this case, I've got them coming in through the adventitial side, which again is kind of an interest. It's not really clear whether they do come in from the adventitial or luminal side. So one of the aspects of saying what does the AT1A receptor stimulation on the smooth muscle do was our interest in the UPA system. And basically the UPA system, I'm sure many of you know, is very critical in the way that plasminogen is derived to plasmin. And again, in some aspects, the interest of this is because of this role as a serine protease that's a very strong activator of many MMPs, which, as you've heard from Rob, is one of the provoking factors that are thought to be pivotal for the generation of human aneurysms. Gary and Jim Wang, when they were at Berlex, have provided plenty of evidence that this system might be involved in this model. That includes this paper in 2001 in which they showed by Western real-time enzymography that UPA is increased in this particular model. And also in a subsequent study, they showed both in AAAs and in normal lipidemic animals that if you had a deficiency of UPA, you would have a reduction in the incidence of the angiotensin-induced aneurysms. So we had a study that was done by Adam Uchida. He's a Japanese MD, PhD. His name actually is Adam. This is not one of these things that we've given because we can't pronounce his name. His dad is a vascular surgeon, and he happened to be born while his dad was on a sabbatical in the US, so he was given an American middle name. In fact, he noted at a recent lab meeting that he's one of the few people in my group that can actually vote on November 4th, which is rather paradoxical. So what Adam did was, the thought was that to take out UPAR, both in doing bone marrows and the whole body, we could show that that might be one of the steps that the angiotensin receptor was interacting with smooth muscle to cause this disease. So Adam has done, this is a huge amount of work that he's been doing for about 2 years that he's been in Kentucky. He's basically bred up UPAR in an LDL receptor background. And the bottom line is that after he's gone through all these hoops to make sure he has the right phenotype and genotype, it's very clear in our hands that the UPAR has absolutely no effect on the development of these diseases. And he has actually done a bone marrow experiment for reasons that I could talk about afterwards, and also shown that the absence of UPAR just in a bone marrow cell or a non-bone marrow cell doesn't make any difference. So there's not any evolutionary changes that we can obviously see that can account for the absence of the UPAR effect in our particular hands. I should mention, again, I just wow, this has rearranged pretty interesting. I should just mention that I talked to Gary just briefly about this earlier on, that we went back and did the UPA mice as well. And one of the aspects is that we thought that maybe, this was uncovering something interesting, that we could not reproduce the UPAR, or could not define an effective UPAR, and it would distinguish, UPA. In fact, in our hands, when we've done UPA in a LDL receptor background, we also could not find an effective UPA in terms of aneurysm development. And in fact, in our hands, the UPA knockout actually tended to die a bit more of rupture, which was a bit unexpected to us. And we actually, obviously one of the differences there is the original study was done in ApoE background as opposed to our LDL. But we did order the normal epidemics from Jackson, and we infused those. And again, at the moment, with the groups of animals which are not quite as big as we'd like, but getting reasonable, you get a lower incidence, but at the moment we can't see an obvious change in the incidence of aneurysm between the UPA deficiency and the UPA wild type. And that rupture aspect that I mentioned, Adam has done, as I say, a lot of bone marrow experiments, and it seems like the rupture phenotype does seem to have something to do with UPA in the bone marrow as opposed to the whole body. So at the moment, this scheme of ours that we put into this grant seems to be holding up in some areas, but not holding up in others. And we're in the midst of some of these studies also, which frankly seem to be a little equivocal in our great scheme of things here. So everything up to this point is basically how angiotensin can directly affect a cell that can cause this disease. But of course, this entry of these leukocytes into the vessel wall has the potential to be both angiotensin directed and indirected, because there could be direct effects of angiotensin on these cells, but also as a subsequence of the effects on the smooth muscle cell, there could be effects of these infiltrating leukocytes that would be independent of a direct effect of angiotensin. So one of the things that we've been looking at is looking at MyD88 signaling. From the atherosclerosis field, this has been very interesting. There's studies from Mason Freeman and Catherine Moore who's shown this system has a very profound effect on atherosclerosis. And Catherine was good enough to give us her MIDI88 mice to start studies. The only glitch was that they're in an ApoE background, and as you'll see later, everything we've done is an LDL receptor background. So studies I'm about to mention from MIDI88 have been both done in ApoE and an LDL receptor background. So these studies were done by Phil Owens, who's a graduate student who I'm now trying to beat to actually write his thesis. He's going to go on to North Carolina, unfortunately, in the next few months once he's finished his studies. But what we did with the mice that Catherine gave us is, as I say, they came in an ApoE background, and we also bred them back into an LDL receptor background. And the very standard protocol of infusing, looking at aneurysms and athero. And these were not very subtle effects in the MIDI88 scheme of things. You can see that when Phil did these studies in the wild type versus the knockout MIDI88 in either the LDL receptor background or in the ApoE background were totally protective, and also had a very profound effect on atherosclerosis, even when we use extremely conservative statistical analysis, which I think visually you can see it's a very large effect anyway. We talked about this rupture scheme that, again, actually, this is one thing I enjoyed talking to people about during this meeting. When you infuse angiotensin during the first 7 to 10 days, you do get some rupture and subsequent death. And in this case, this MIDI88 deficiency totally, well, not totally, but pretty much protected except for one animal against this, as opposed to what we see in control animals, which again is this death in the first few days, and then it's stable until it actually starts reoccurring, as you'll see on Deb's poster. If you keep on infusing, you'll see aneurysmal rupture deaths that occur in sort of the 2 and 3 month period. So MIDI88 is a common factor for both two major toll receptors, toll4 and toll2. And Linda Curtis from Scripps was good enough to provide us with both the TLR4 and TLR2 knockouts. And just as a very broad overview of this massive amount of data that Phil's accumulated, is that when we've done this experiment into the TLR4 deficient animals, you can see that there's a very profound difference, and one that's fairly similar to that we've seen in the MIDI88, whereas very small numbers at the moment, but at the moment we are seeing no effect of TLR2 deficiency. So it seems like the axis that we're looking at is a MIDI88 TLR4, and at the moment I can tell you we're not sure it's a direct effect of angiotensin. We think it's just that the angiotensin infusion set up a sequelae so that you'll get this infusion of leukocytes. So the proposed scheme at the moment, as I've put up a few times, is around here. And one of the aspects that, again, I just throw out there as an interest to us that we're still trying to scratch our heads as to really how to define it, is it's obviously going to be important to know whether these cells come in from the adventitia or from the lumen, because there'll be very different mechanisms potentially that will guide those cells to that spot where the disease occurs, and also the requirement to get those cells inside the lumen. I must admit my prejudice is just that it is an adventitial entry, just because I've been looking at athero for years and years, and I very seldom, if ever, have seen a macrophage infiltrate that's done anything that go beyond the internal elastic lamina, except at very late stages of the disease. Whereas in this particular model, having macrophages present in the lumen is a pretty common occurrence, and it just seems to be very dichotomous to me. So just to give you an idea, the University of Kentucky group, we have got a PPG that a lot of you in this audience actually have been very gracious in helping us out review this. I did have some male colleagues in this at one time, but they got kind of cut out in the review process. And Lisa, Nancy, and I have got projects which define different characteristics of this model, and we're supported by having a pathology core, and as you'll hear, a lot of animal breeding, which is very critical, and animal phenotyping to do the ultrasound, to do the blood pressures, and make sure all that is highly quality controlled. I guess the last thing I just wanted to mention, Ron kind of mentioned this, is that I had the privilege of being the chair of ATVB for the past couple of years, and I'm now chair of the meeting that's going to occur in this spring. And we're going to do this in conjunction with the Society of Vascular Surgery, where the Society of Vascular Surgery is going to meet on the Tuesday, April 28th, and then the ATVB meeting is going to start the next day, and we're coordinating our program. So we certainly hope that you'd save this date, and that we'll see you all there. With that, I thank you for your attention, and welcome any questions.
Thank you.
I think the short answer is I have no idea.
I think
I'll keep asking this.
That's the engineering part of the meeting.
I'll keep asking this question every session.
Yeah, well, it's not just our model actually. So I forgot to mention this, but ApoEs and LDL knockouts get aneurysms spontaneously. So I think all we're doing by infusing angiotensin is speeding up the process. We actually just took a study down this week where we had some 7 months fed animals for a variety of reasons, and one of them had just a huge aneurysm there. So it occurs in naturally angiotensin infusion, all those people that I listed, it's always been in the same area. And I have no idea. I mean, I assume it's some biomechanical effect. We've been trying to get Ron to do some stress studies for us, and I know the people at Emory, Bob Taylor's been trying to do this. I have no idea why it's so local, but it's very reproducibly local.
I think that falls to the hemodynamic part of the equation, which we're going to segue into here shortly.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.